Good afternoon, everyone. My name is Dr. Sonia Mather. I'm a family physician, and also I've been living with Parkinson's disease for now over 20 years, almost 22 years. I have the privilege of serving on the board of directors for the Davis-Phinney Foundation, and I have the distinct pleasure of being your moderator today. As we all experience, and if we're a care partner, as we watch our loved ones experience, Parkinson's disease goes much beyond the motor symptoms of tremor, stiffness, slowness of movement. This disease affects us globally with non-motor symptoms presenting in almost every bodily system. This in turn affects us not just physically, but emotionally and mentally as well. And these non-motor symptoms, particularly mood disorders, can have a really significant impact on our daily life, or on our quality of life. So today we're going to explore further the topics of depression and anxiety in Parkinson's disease, how they are related, how to recognize the symptoms, the treatments that will benefit us, both medical and non-pharmacological as well. And we're also going to discuss the topic of apathy, which is a very common and impactful symptom that goes beyond the sort of general fatigue that this disease brings to us. To help us tackle these important topics is today's Dr. Gregory Pontone, an associate professor in the departments of psychiatry and neurology at Johns Hopkins University School of Medicine in Baltimore, Maryland. He is also director of the Johns Hopkins Parkinson's Disease Neuropsychiatry Clinic, and both his clinical work and research are directed towards neuropsychiatric symptoms in Parkinson's disease, such as cognitive impairment, anxiety, and depression. Welcome, Dr. Pontone.
Thanks for having me.
So maybe to get started, we might want to start off with sort of defining what this problem is in terms of how common is depression and anxiety in Parkinson's disease.
Well, it turns out that most disturbances of mood are overrepresented in Parkinson's compared to the general population. And there's several reasons for that. One is the biology of Parkinson's itself. So in addition to depleting dopamine in the brain, it also depletes or perturbs the concentration of neurotransmitters like serotonin and norepinephrine, which are vitally important for mood regulation in addition to dopamine. And so when you think about depression, and I don't mean just being a little down or sad, but what we would clinically classify as depression, about a quarter, 25% of people with Parkinson's will experience a major depressive episode at some point during the illness. And at least half will experience symptoms that are impactful on their day-to-day life over the course of the disease, even if they don't have a major episode. Now, the interesting thing about depression and Parkinson's disease is that it is very often accompanied by anxiety, such that I would say that if you're diagnosed with or suspect that you have depression, your doctor should also screen for anxiety because they occur together in the majority of cases. Anxiety is also very common, probably occurring in about half of everyone with Parkinson's disease at some point in terms of having a clinically important symptom, and a full-blown disorder, something like panic disorder, or what we call generalized anxiety disorder, occur in up to a third of people at some point with Parkinson's.
And how do these numbers compare to the general population?
So if you look at the World Health Organization, depending on which category you're looking at, these are all elevated above the general population and elevated beyond that other neurological diseases as well.
That's interesting, actually, that it would be such a significant difference. But I mean, I think a lot of us have an idea of what depression and anxiety are, but how can they be distinguished from changes that we would normally experience, sort of being sad or stressed about our diagnosis of an incurable progressive illness? How do they differ from just feeling down about things?
Yeah, I think that's probably the most important point here, is that the depression and anxiety that we're talking about are to the extent or severity that they interfere with functioning. Whereas, you can be down or blue or what we call demoralized and still function. When you're sad or depressed or uninterested to the point where you're actually not completing your day-to-day activities, that's when it crosses the line and becomes a clinical disorder. And in large part, we think that's because it's biologically based. You know, if you have Parkinson's, you can't just decide to wake up and move better. You know, you need a little help from some medication. I mean, certainly exercise and the things that you do are very important, but without that dopamine, you know, you're just not going to move well. And in the same way, when you have a clinical biological depression or anxiety disorder, it doesn't matter how disciplined you are, how hard you try, how much support you get from your spouse or caregivers, you're going to need a little bit of biological help in the form of medications to fully recover. Now, that said, just like the physical problems in Parkinson's, being active, talk therapy are all really important. But I just want to make this distinction because oftentimes I think, you know, people who are motivated and disciplined their entire lives get depressed. And then it's almost as if the community turns on them and says, all of a sudden you're lazy. And that's not the case at all. It's, I mean, a kick in the pants is not going to fix these problems. They're like any other medical condition, you need to be treated.
I think that's a really important point because I remember when I was in family practice, that stigma attached with mood disorders was so significant that patients would often not come in to get the help they need. And I would tell them, you know, it's like breaking your arm. You wouldn't walk around with a broken arm. You need intervention. So why wouldn't you come in for your mood? But I think there's unfortunately that stigma that's attached. But that distinction about what you're saying about how the mood impacts on functioning, I think is really important for us to remember. But clinically, how do you diagnose it as a neuropsychiatrist? Because we have symptoms of depression sort of anyway. When a patient with Parkinson's comes in with slowness of movement or loss of appetite or weight loss or poor energy, I mean, all symptoms of depression and Parkinson's, how do you kind of distinguish between the two?
So that is a great question, and that's the key clinical sort of differential, is how much of this is a symptom of Parkinson's and how much of this is attributable to the depressive disorder because of that overlap. So, you know, low energy is a symptom of both depression and Parkinson's. So if you have potentially both, how do you know which one is causing it? And so because we treat depression as a syndrome, we have a threshold of 5 symptoms or more in order to meet the threshold for a major depressive disorder. And, you know, there are things like sad mood, although you can absolutely have a neutral mood and still have depression. I think that's probably one of the other important points is just losing your sort of motivation or interest in things is sufficient. You don't necessarily need to be sad or tearful to have depression. In addition to that, people often feel guilty or hopeless when they're depressed. People often have a sense that life isn't worth living, or sometimes they become frankly suicidal. Those thoughts are not normal. I mean, if you get demoralized, you might think that maybe you weren't as successful as you could have been, or that you've missed some opportunities, but it's rare for a person who's only demoralized to become frankly suicidal. And then there's another category of symptom that we call neurovegetative symptoms that I think are very important in making the diagnosis of depression. So these are things like psychomotor slowing. So in Parkinson's, when you move slowly, we call it bradykinesia. When we talk about depression, there's a symptom called psychomotor slowing or retardation that is very much like bradykinesia, but it affects even more of the functioning. So not only do you move slowly, but there can even be what we call speech latency. So I'll give you an example. People who are psychomotor slowed when they're depressed, you ask them a question, you say, Mrs. Smith, how's your mood today? And then I always tell my residents, I say, count 1, 1,000, 2, 1,000, 3, 1,000. And then she responds. That's speech latency. So there's a delay in her cognitive processing and then her verbal response. And that's very characteristic of a moderate to severe depression. Sleep disturbance, again, that can be the Parkinson's or the depression, but sleep disturbance is very common in depression. In fact, not only is it a symptom of active depression, some people believe that sleep disturbance might be a prodromal or early risk that leads later to depression. Appetite disturbances. So in depression, it can go 2 ways. The most classic appetite disturbance in depression is lack of appetite and weight loss. But there are a substantial number of people who have what we call an atypical depression, where their they eat almost to comfort their emotional state. So they overeat. And those same people who tend to overeat with depression tend to oversleep instead of have trouble with insomnia. And then, loss of energy and then poor concentration are also symptoms that can happen in depression. And the concentration problems in depression can be very severe. In fact, one of our biggest sort of mimics of dementia, not just in Parkinson's, but in the general elderly, is depression. So you can be so profoundly depressed that you appear as if you're demented in terms of your cognitive functioning. But the great news is that if it's from depression, we can reverse it.
That's amazing. One of our listeners asked a question. They said, I seem to need a lot of sleep, 9 to 10 hours. Could this be a sign of depression, or is it PD related issue? I don't feel depressed during waking hours.
Yeah, so I guess the first caution would be if this is a change from your usual pattern of sleep. So let's say for the majority of your life, you've only required 6 to 7 or 8 hours, and all of a sudden you're sleeping 9 or 10. The first thing I would tell you, and I think if you have Parkinson's, you know this better than me, although I've seen thousands, it is one of the most fatiguing diseases. So I would say almost certainly Parkinson's is contributing. It is, it's like carrying sandbags around all day. And so that could contribute. Depression, as I described, especially an atypical depression, you might need more sleep. Sleep fragmentation is another reason. So even though you're sleeping longer, the efficiency of your sleep could be diminished. So the reason you're in bed 9 to 10 instead of 6 to 8 hours is because when you are sleeping, it's in the lighter phases or the less restorative phases of sleep. And so the thing that we would usually do in someone who's sleeping more than usual is, go get blood work, check your thyroid, have a test for sleep apnea, right? And, maybe even have a sleep study to see if there's fragmentation in your sleep architecture.
Is there a difference between the type of sleep disorder that you get with Parkinson's disease versus depression? I know you mentioned the difference, but.
No, absolutely. So, there's many different ways that sleep can be disrupted, either due to Parkinson's or from depression. But one of the most classic things we see in depression is what we call terminal insomnia, which is early morning waking. So waking before you'd ideally like to, before your alarm clock goes off, and being unable to return to sleep. And the classic pattern is you wake, a few hours earlier than you'd like, and you start ruminating, bad thoughts usually.
Mm-hmm.
And so that would be one of the patterns, but I've seen it manifest in many ways: middle waking, trouble falling asleep. And then of course, with Parkinson's,
mm-hmm.
the urinary urgency. Some people take doses in the middle of the night. If you take immediate release dopamine before bed, that can be activating. If you don't take some dopamine before bed, you can wake up because you're stiff. And so I think sometimes journaling why you wake or what's associated with the sleep disruption can
mm-hmm.
help your doctors put together which disorder it might be attributable to.
Do you get REM sleep behavior disorder in depression, or is that sort of exclusive to Parkinson's?
Yeah, so there can definitely be what we call a decreased REM latency in depression sometimes, meaning that you fall asleep and go immediately into REM instead of sort of building toward REM. But otherwise, the REM sleep behavior disorder, unfortunately, that the majority of the time that's going to be associated with something bad, like an alpha-synucleinopathy, like Parkinson's or dementia with Lewy bodies. Yeah, we don't necessarily see that as a symptom of depression.
Okay. You mentioned this, I think, at the beginning about what causes clinical depression and anxiety and why it's more common in PD. Could you elaborate a little bit more? You were talking about dopamine and other neurotransmitters.
Yeah, so this is, I want to back up a little bit because
mm-hmm.
what we call Parkinson's disease
mm-hmm.
is probably more than one disease. Many roads lead to Rome. And I think that's the case in Parkinson's. But even today, we're learning more and more about the genetics of Parkinson's, but the lion's share, maybe 80-85%, is still what we consider to be sporadic Parkinson's. Mm-hmm. And in that sporadic group of people with Parkinson's, there's a model by Hiko Brack. He's a pathologist, and he stages Parkinson's into 6 stages. And he thinks that in the sporadic cases, many of them actually start in the gut. We find Lewy bodies in the nervous system part of the gut. And then maybe by going along a nerve called the vagus nerve that feeds sort of the gut and innervates the gut rather, these Lewy bodies go into the base of the brain stem, okay, into the motor nucleus of the 10th cranial nerve, which is the vagus nerve. Mm-hmm. We find Lewy bodies there. And then this is where it gets interesting in terms of connecting to depression and anxiety and Parkinson's and why this might happen. So that's a stage 1 structure, is that brainstem. And just above that is what Brack calls the stage 2 structures. They're called, 2 of them are called the raphe nucleus and the locus coeruleus. So the raphe nuclei produce serotonin, which is crucial to mood regulation. In fact, most of our antidepressants work by increasing the levels of circulating serotonin. The locus coeruleus produces norepinephrine. So not only is norepinephrine a dopamine precursor, norepinephrine is also a brain chemical important for mood regulation. And it's probably the second most popular thing found in antidepressants is norepinephrine. And we know that Parkinson's affects those 2 brain areas, right? Mm-hmm. And depletes them of the norepinephrine and serotonin. And we know both of those are important for mood regulation. And then it's only after those stage 2 structures that we know are involved in mood that it goes to the stage 3 structures, which include the substantia nigra, and that's where we start to lose the dopamine in Parkinson's. And so there's your trifecta: serotonin, norepinephrine, dopamine, the 3 most important chemicals in mood. And we're not guessing. We know that probably in the majority of cases of Parkinson's, all of those systems are affected by the disease, and the chemicals that are important for mood are decreased.
That might help explain why we think that depression might be a pre-motor symptom for Parkinson's disease if it's in that kind of stratification. That's very interesting. Just to move on a little bit, you described some generalized anxiety disorder and panic disorder, but in general, what are the different types of clinical depression and anxiety? How do they manifest in patients usually?
Yeah, so I guess starting with anxiety, because we've neglected it a little, there's kind of 4 DSM, so diagnostic and statistical manual anxiety disorders that are well represented in Parkinson's. And so generalized anxiety occurs in about 13% of people with Parkinson's when they have an anxiety disorder. Mm-hmm. The panic disorder is also up there in terms of prevalence, not quite what generalized anxiety is. Social phobia is very significantly associated with Parkinson's, and some of that is, probably biological, but some of it is also being self-conscious about symptoms and things of that nature. And then the sort of third one that we see quite a bit of that we think might be fairly unique to Parkinson's is a fluctuation, so on-off dopamine medication fluctuation associated anxiety. And so what people typically describe with that anxiety, and this might be as many as a third of the cases of anxiety we see in Parkinson's, is that when they take their dopamine, their motor symptoms get better and they turn on, but then as they start to wear off just before the next dose usually, they get really anxious. And that's the off state, as they enter the off state. And we think that unlike anxiety in people without Parkinson's, dopamine may be part of the answer for treating that type of anxiety. Now, about a third of people who have any of those anxiety disorders I just mentioned in Parkinson's will have more than one. So again, once you find an anxiety disorder, look for other anxiety disorders and also look for depression. Now, depression, and I think this is important, is, major depression is the one we worry about. But like I said, about half of people have clinically significant minor depression that isn't, the full syndrome. Mm-hmm. But what we found is that if you don't identify and treat that minor depression, the risk for a major depression goes way up. And so, our message is always that if you're a little bit depressed, work with your doctors and do something about it, because it leads to higher risk of the bad type of depression.
Right. And that brings me to the question that was also posed by someone who's listening, that in terms of your medical treatment, would a neuropsychiatrist or a psychiatrist who specializes in movement disorders be sort of better able to care for someone compared to a general community psychiatrist?
Well, that's the argument for my career, but the fact is that not many people do this. And so, I don't think that that's going to be accessible to most people, but I will tell you that a good geriatric psychiatrist, a good neuropsychiatrist, or just a psychiatrist who's paying attention and willing to work with your neurologist can do all these things reasonably well. The one that's a little trickier is when the anxiety is associated with the on-off fluctuations. But even that, I think, can be remedied as long as you make sure that your care team is talking to one another. So if you have a good neurologist and a good general psychiatrist, I think they can work together as long as they're communicating and solve these problems.
Yeah, the communication is the key thing for many aspects of our care, for sure. Can we talk a little bit about the treatment, the pharmacological treatment versus the non-pharmacological treatment of depression and anxiety? Are they the same, or do you have to approach each differently?
Yeah, so I'm going to give you the good news first, and then I'll tell you the stuff that we still need to do better on. So
Okay.
The good news is that for depression and Parkinson's, we have great treatments. We have treatments that are at least as good as in the general population, and we have good evidence for those treatments. Antidepressants, the same antidepressants that we use for anybody's depression, seem to be effective in Parkinson's disease. I'm going to give you just a few names, and these are names that have the best evidence currently. It doesn't mean that other things don't work. It just means if you were to just choose one as a first choice, these are the ones that have been tried and true in Parkinson's. The first one, it's from a trial called SAD-PD. That was a multi-center trial, including Hopkins as one of the sites. Irene Richard actually was the main PI at University of Rochester. She's excellent clinical trialist, put together a really great trial. Effexor is the brand name of the medication, or venlafaxine is the generic. Effexor is what's called an SNRI, so it gets a little bit of serotonin, norepinephrine, so your raphe nuclei and your locus coeruleus. It's got all the bases covered. It's a medication that's been around for a long time. It's generically available and affordable. It's generally well tolerated, and it right now has probably the best evidence of any single agent in Parkinson's for treating depression. And the other really nice thing about Effexor is it's used equally as often for chronic pain. And I can tell you, the people that I work with who have Parkinson's, pain seems to be a common symptom as well. So a lot of times you could get a 2-for-1.
Yeah, that's an added benefit for sure.
Absolutely. So that's the best evidence. Now, there's other medications that also have good evidence. So the SSRIs, the things like your Zoloft, sertraline, Paxil, citalopram, Lexapro are all good choices as well. And they might even be a little better tolerated than the Effexor on average. They just don't have that benefit for pain that Effexor does. Other medications like Wellbutrin, many people use that. Unfortunately, it doesn't have the same degree of trial evidence, but I can tell you that anecdotally in our clinics, we use Wellbutrin very often. That other advantage of Wellbutrin is it doesn't interfere with sexual function, and that can be a big thing because almost all those other antidepressants can interfere with sexual function. And so Wellbutrin is a nice option if that's a important thing, or if you're one of the people who gets the sexual side effects from the other medications.
Right.
So there's all types of little tweaks, but the good news is that most of the antidepressants we have, regardless of class, seem to work well in Parkinson's disease.
And does that hold the same for anxiety? Would you use these same medications for anxiety as well?
So we use them, but the problem is, unfortunately, that we don't really have any clinical trials directly supporting the treatment of anxiety with medications in Parkinson's. So we have pretty good trial evidence that cognitive behavioral therapy works well for anxiety in Parkinson's, but there aren't any currently trials to support medication use for anxiety and Parkinson's. And that's something we're working on,
Right.
but it's a little difficult because we use a lot of benzodiazepines outside of Parkinson's, but benzodiazepines, which are a good anti-anxiety medication, probably have additional risk in Parkinson's because they might increase the risk of falls, they might increase the risk of cognitive impairment and sedation. And so they might not be the ideal. I'm not saying don't use them, but you use them with additional caution in Parkinson's. And then our main treatments for anxiety in the general population are a lot of those same antidepressants I mentioned before. So Effexor is effective for anxiety in many cases. The SSRIs like sertraline are effective for anxiety. They take long time to work, you know, a month or two before they kick in, but they're generally well tolerated. But we think they probably miss that fluctuation anxiety. They don't seem to do much to modify that. We need dopamine.
Do you find that, considering anxiety and depression often occur in the same patient, that if you sort of solve the depression, the anxiety tends to go as well? Do they go away together, or are you left with anxiety at times?
Again, yeah, I think it depends. The majority of the time, they'll go away together because, for instance, if you use an SSRI or Effexor, it's usually equally good for the depression and the anxiety. But if you have one of those more dopamine-based on-off fluctuation anxieties, their mood will get better and they'll still be anxious, especially at the end of dose or with fluctuations. So it's definitely something that we need to, you know, do more to investigate.
And do any of these medications interfere with any of our Parkinson's medications? Do we have to be cautious about interactions between the two?
So this is one of those things where I'm going to give you a party line answer, and then I'm going to tell you what happens in real life. So many people are on Rasagiline or Azilect. It's an MAOI, so a monoamine oxidase inhibitor. And so all those brain chemicals that I talked about that are important for the regulation of mood, the dopamine, the norepinephrine, and serotonin, that MAOI, Rasagiline, increases the concentration of those by blocking their breakdown. And so theoretically, if you were to use one of those antidepressants I mentioned, along with Rasagiline or one of the MAOIs, Selegiline is another one, it could build up and cause what's called a serotonin syndrome, which is too much serotonin, and that can be dangerous. And if you get a prescription from your neurologist for the Azilect, and then you get a prescription for an antidepressant from your psychiatrist, your pharmacist is going to send a dirty letter to both of them saying you shouldn't use these together. But I have to tell you that there is a scientific literature in Parkinson's showing that we use these things together all of the time with a good safety record.
That's interesting. A patient's asking, is Trazadone no longer considered a choice?
So that's a very interesting question. So Trazadone is actually an old antidepressant that is no longer or very rarely used as an antidepressant. It's used as a sleep aid because it's very sedating. And we use it at doses lower than we use it as an antidepressant. Its mechanism is pretty interesting. So most of the antidepressants that interface with serotonin today are what we call selective serotonin reuptake inhibitors. And so they stop the reuptake of serotonin, which increases the intersynaptic serotonin. Trazadone is what's called a SARI or a SARI, S-A-R-I. And so basically it's a serotonin agonist. So it more directly stimulates serotonin, which, you know, who knows, may have unique properties. And in fact, some new molecules are coming out that have that serotonin agonist property. So you may see a recapitulation of drugs like Trazadone, hopefully without the sedating properties, becoming more mainstream antidepressants again. So I wouldn't say there's no role for Trazadone, but for instance, most people, it would be too sedating to use as a main antidepressant therapy. So we use it mostly for insomnia.
So you mentioned sort of things coming down the pipeline. Is there a lot of research going on in Parkinson's disease and mood disorders?
So not necessarily specifically in Parkinson's disease, unfortunately, but in the general population, new molecules for the treatment of mood that can then be carried over to Parkinson's are coming along all the time. And I have to tell you, every time I give a talk and I tell them about why Parkinson's is such a wonderful disease model for understanding the broken part in mood disorders, they say, well, maybe you can help us find better mechanisms, you know, by what you know of where the Lewy bodies are and in Parkinson's. And so, for instance, somebody just approached me about using ketamine for Parkinson's depression. And ketamine, I don't know if you're aware, but ketamine right now is one of the hottest new antidepressant therapies in the nation right now. It works much more quickly than our existing antidepressants, and it has a sort of novel mechanism.
That's very interesting. We've talked a lot about the pharmacology behind treatment. What are some of the non-pharmacological treatments that you recommend to patients? You mentioned cognitive behavioral therapy for anxiety. Could you maybe describe a little bit about that and maybe some other interventions?
Yeah, so I think this is one of those things where, not that everything leads back to exercise, but there is great evidence that physical exercise is great for depression and anxiety and cognition. And that's in addition to, we know it's probably the best thing you can do for your motor function and to slow down progression of the disease. So I guess the first thing I would say is, if you're not exercising, why? Because it's going to help pretty much everything that happens here, whether it's, on the mood side or the motor side.
Right.
So in terms of therapies, cognitive behavioral therapy has great evidence in general for helping mood disorders of all kinds. And so what cognitive behavioral therapy does essentially is it looks at our thoughts and our behaviors. And when we have a sort of self-defeating cycle of thoughts and behaviors, it helps to realign that. So whether you're actively depressed and there's a biology behind it, or you've recovered from depression, but you're stuck in bad habits, cognitive behavioral therapy is a great option, because we think that when you're depressed, that the biology produces what we call automatic negative thoughts. Like, I can't do it. I'll goof it up. I'll lose. And so you're sort of self-defeating, and then your behaviors follow that. Well, if I'm going to lose anyway, why get off the couch? If, even if I exercise, I'm not going to move better. I have Parkinson's. And then, you're just in this downward spiral. And so what cognitive behavioral therapy does is it teaches you first to recognize the automatic self-defeating thoughts, and then to not let it lead to what truly results in bad outcomes, which is the behavior of not getting off the couch to do what you're supposed to do.
And who can do cognitive behavioral therapy? Which allied healthcare professional or healthcare professional is in charge of that, I guess?
Yeah, so the good news is that it's ideally a number of different people can do this. So psychiatrists, psychologists, social workers, licensed therapists. The problem is who can do it well. And the one piece of advice I give people is, ideally start first with your insurance provider. See if there's anybody who is sort of certified to give CBT who also takes insurance. Sometimes that can be rare, but start at least there. You'll have a list to go by. And then don't be afraid to walk in and walk out if you don't have a rapport with the person, because whether it's cognitive behavioral therapy or a more, psychodynamic therapy, you have to have a rapport with this person, because you're going to spend more than a few hours in front of them.
Yeah, no, I think that rapport issue is important for all members of your healthcare team, but particularly, I guess, someone that you're going to receive counseling from. Somebody asked about TMS, or transcranial magnetic stimulation. Is there any evidence or experience with that in depression and anxiety?
In Parkinson specifically, absolutely. Yeah. So I want to address this in a very broad way. So brain stimulation in general appears to be a good and evolving option in Parkinson's disease and outside of Parkinson's. So the first thing I would say is RTMS. I know people who get that on their lunch break and go back to work. And so RTMS is usually very well tolerated. The one little issue with RTMS is, if you stop, it doesn't necessarily have an enduring benefit. So you have to get repeated treatments, and it's really only good, or its indication currently is only for up to moderate depression. The more severe depressions, it doesn't really do a great job on. But I think you're going to see that treatment is going to evolve. In fact, I think ultimately it may become one of the mainstays. The other one that we don't talk about much, but I think I at least want to put a plug in for, is ECT, electroconvulsive therapy. And this is sort of the big brother of RTMS. And that's basically where we give you enough of a current to induce a small seizure. And it is, to this day, it's one of the earliest, but to this day, it is one of our most effective and fast working depressant treatments known to man. And this is what people don't realize, is that when we have a pregnant woman who has severe depression, maybe even suicidal, we prefer that over medications, because the medications could affect the fetus, whereas the ECT itself is well tolerated.
Wow.
ECT has been studied in Parkinson's, not just for its mood improving effects, but it's also shown to temporarily improve movement in Parkinson's, independent of whether you're depressed or not. And so when I have a patient with Parkinson's who's severely depressed, or especially severely depressed with suicidal thoughts, ECT is a great option, with the one caution that you have to get anesthesia before each treatment. And so the risk of a confusional state, or what we call delirium, is a little higher in Parkinson's, and so you have to be a little cautious. But otherwise, the evidence is there that ECT is a great option in Parkinson's.
It's funny, these old time treatments, ECT in this case, and levodopa in Parkinson's disease, seem to work phenomenally well.
Oldies but goodies.
Yeah, oldies but goodies. Just to switch gears a little bit, I'm getting a lot of people that are interested in knowing, as care partners, what they can do when they sort of notice changes in their loved one's mood, maybe even before the person with Parkinson's does. What do you recommend to care partners?
Yeah, I think this is tough, because depression most often is insidious. It's not like a lightning strike, like you go to bed fine one night and you wake up the next depressed. It sort of creeps in, just like the movement changes, right? First you get a little twitch in your finger, and then the next thing you know, you're tripping over your own feet. Same thing with depression. You're a little less motivated, you enjoy things a little less. Pretty soon you say, geez, I haven't been out of the house in a week. And so I think the first thing that a good care partner should do is help bring this to clinical awareness. Like I said, a little depression most often leads to a worse depression later if it's unrecognized or untreated. And the thing is, it's depression often isn't gonna, it's not flamboyant. It's not gonna, you're not gonna shoot blood out of your nostrils. You're not gonna do Hollywood things. It's gonna be, you just sort of fade away from all the things you used to enjoy. And I think when you see that, get excited, because they're not going to get excited. They're too depressed to be excited. So make sure that you help them get attention for this condition.
Be an advocate, I guess, for your loved one, I think is important. We talked a little bit, and I talked a little bit in the intro about discussing apathy, and I think we should maybe touch on that. I mean, that's something that's quite common in Parkinson's disease, something that can really be quite insidious and can really negatively impact a patient's quality of life. How would you define apathy, first of all?
Well, I think probably one of the best ways to tell you about apathy is, I have most of the patients that I work with, I've worked with for 10 to 20 years. So, I have relationships with these people, and they tell me all kinds of great stories, or their loved ones tell me stories. And the story for apathy that sticks in my head is, this guy was he had a great sense of humor. And I asked him one day, because it wasn't him. He didn't care. He was apathetic. It was his wife who was all wound up because he did nothing, right? He sat on the couch all day. I asked him, I said, Mr. Smith, whatever his name was, right? Do you know the difference between apathy and depression? He goes, I don't know, and I don't care. And I said, that kind of summarizes it, right? He didn't care. And so to me, apathy, most often, the patient isn't going to come to you and complain of apathy, because they literally don't care. They don't, good things, bad things, doesn't matter. And so the example is, it's going to be the family that comes to you saying they don't do anything. It's hard to motivate them. When I do motivate them, it looks like they're just going through the motions. And this woman comes to me and says, the other day, my husband's sitting on the couch watching the World Series. He's been a lifelong baseball fan. The power goes out, right? Comes back on, but the cable doesn't come on. So he's watching snow. And she says, well, I'm just going to see how lazy he is and see how long he sits there watching the snow. An hour goes by, and he sits there watching the snow almost as contentedly as he was watching Game 7 of the World Series. And didn't bother to get up and figure out what was going on. And that's when she knew. She said, something's really wrong here. He wasn't even bothered enough to do this. And so when you look at someone who's depressed versus someone who's apathetic, the first thing you're going to notice is there's very little to no emotion either way. I mean, they might get irritable if you try to push them to do something and they just don't feel motivated, but most of the time they're not going to be They don't feel guilty about not doing anything. They don't feel sad. You know, they're not, when you come over to them and say, why are you doing nothing? They're not, it's not because they're sad. They're not going to be suicidal. Apathetic people aren't suicidal. It's, you know, they don't care. So you really have to kind of look for the things that aren't there to rule out the depression. I mean, you can have all those things in depression, you know, the lack of energy, the lack of motivation, the lack of enjoyment, which we call anhedonia. But usually with depression, you'll also have this negative component of, you know, either irritability or sadness or hopelessness that just isn't there in apathy. The other really interesting thing about apathy, and this is, you know, holds up in the research, is that apathy seems to go in parallel with cognitive decline. So often what we see is that there'll be at least subjective complaints of either memory loss or disorganization along with the apathy. Whereas with depression, you know, it could have a problem with concentration, but when you treat it, it goes away. With the apathy, sometimes it's there to stay. It seems to track with that. And then the best evidence for treating apathy isn't antidepressants. It's acetylcholinesterase inhibitors, which acetylcholine is what we use when people have dementia or cognitive problems. And that's what apathy has the best evidence for. And so when I think about it in terms of mechanism, it seems to be more linked to a decline in the cognitive part of motivation than the mood or what we call affective part, which is more with depression.
Right. But that's not to say everyone who experiences apathy will go on to experience dementia.
Not at all. It's just more, it's just on average more linked with cognitive trajectory than depression is in general.
Okay. You mentioned acetylcholinesterase inhibitors. What other medications are we using for apathy, or are there any?
Yeah, so right now, the two, and this is a little tricky, the two best evidence treatments for apathy and Parkinson's are acetylcholinesterase inhibitors, and specifically this was done with rivastigmine, which is brand name Exelon. It probably is a class effect, meaning that other acetylcholinesterase inhibitors are useful, but the studies were done in Exelon, which is the one that's FDA approved in Parkinson's. And the other ones that show evidence, but they show evidence mostly in a specific case of people who've had STN, deep brain stimulation, is the dopamine agonists. And so the idea is that in some people with Parkinson's, the apathy could be a consequence of low dopamine, and that if you restore dopamine, specifically maybe dopamine that hits the D3 type of receptor more so than the D2 receptor. D3 we think is more involved in mood and motivation, and D2 more directly in movement, which the agonists tend to hit a little more at D3. That might help apathy. But those are the two best evidence treatments right now for apathy and Parkinson's.
And what about non-pharmacological treatments? Or, I mean, apathy can certainly interfere with the proactive approach we need to take when it comes to Parkinson's. We need to exercise, like you mentioned. We need to keep up with our self-care routine and so forth. So how can apathy be managed by the patient or the patient's family?
So apathy, like I said, you know, because oftentimes it's happening in parallel with cognitive changes, providing a structured environment is key. So I'll give you an example. So, you know, you're lacking motivation, but most of the people I work with who have apathy, if you take them somewhere, they'll go along. You know, the depressed person's like, nah, and irritable and won't get out of bed. But the apathetic person will be like, okay, path of least resistance, you're tugging on my arm, I guess I'll go. And they get there, and sometimes they can rise to the occasion. And so what we found is the best outcomes are when you sort of provide a structured day for the person. And so there are programs, day programs for people with apathy that would be great. But even if you're not in a program, you know, just having the care partner or spouse basically say, hey, on Thursdays, we're having lunch with this group of old friends you enjoy. And that really goes a long way. In fact, I can tell you, even though I mentioned those two medications, the best outcomes we've had are when we can motivate the family to really arrange even just a few activities to look forward to during the week.
And that kind of ties into this one question that I've gotten. The person wants to know, they say, so aside from going to the doctor or the person with Parkinson's, how can a care partner deal in the moment with someone who won't do anything like exercise, even if they know it could help?
Yeah, well, exercise, you know, my thought about this is, if someone was an athlete and they exercised most of their life and then all of a sudden they don't, that's one scenario. But then if there's a person who is sedentary their whole life and now you expect them to exercise because they have Parkinson's, that's a bigger challenge, because, you know, even without depression or apathy, if it's not part of your repertoire of behaviors, that's going to take some doing. And so, you know, you have to get creative. I have to tell you, some of the best care partners are the most creative care partners. You have to incentivize what you want. And so, and I think a good physician, you know, we are always taught that persuasion and healing, you know, you have to be able to persuade people to see things your way and to agree with the evidence if you want to help heal them. And so I think this is really a negotiation. You have to find something that makes sense in their world in order for them to adopt these new habits. The good news is like any habit, if you can get them to do it for a few months, it'll become easier and more automatic. So I always tell people, like, I'll fight with you for a couple of months, because once we get them on the tracks, that train will chug along by itself. And I think that's the key, is as long as nobody gives up and everybody is on the same page, you know, if you get them, the first thing is to get them to agree that they think exercise is important. Persuade them of that first, and then you can build the rest around it. But it's going to be a challenge, and it doesn't even have to be that they're depressed or apathetic. It just look at their life, and that'll tell you a story.
We all need convincing at times, for sure. Another wife has written in about her husband, which I think it's kind of a situation that a lot of people experience. She says, my husband was diagnosed with Parkinson's 2 years ago, but looking back, I started seeing his behavior change and chalked it up to his getting older. He just turned 64. He doesn't converse much. He feels uncomfortable in social situations, like he's afraid he won't be able to find the words that he needs to hold a conversation in the group. He's become very unsure of himself. I have to keep the conversation going, no banter between us anymore. What, if anything, can I do to help him? What would you advise that care partner other than what you've said?
Yeah, the first thing I would do is get him screened for depression, because a lot of times a withdrawal like that, that's a hallmark of depression, is all of a sudden, I mean, and you rationalize it, you blame it on, you know, and maybe it's true, you're having a little bit of word finding difficulty, and some of that's normal for age, some of that could be the Parkinson's. But the bottom line is, just like I talked about in apathy, you know, the more you withdraw from things, the worse it compounds the problem. And so the two things are, get screened for depression, and number two, keep them out there. You know, whatever, if every time he says he doesn't want to, plan 2 more lunches, you know, or whatever it is that you like to do, a hike in the woods, whatever it is, you have to keep going. I mean, it beats the alternative.
So just for the last few minutes, I just want to go through some of the questions that are there. So it might kind of seem like they're in random order, but someone's asking about light therapy, and is that effective?
Yeah, so one of the experts on light therapy is a gentleman who lives in this area by the name of Norman Rosenthal. And so there is definitely a proportion of people with and without Parkinson's who have a seasonal component to their mood disorder. And it's very profound. In fact, across cultures, I mean, not Western cultures, Eastern cultures. We live near the Amish here in Maryland. We have the Pennsylvania Amish, and then the more Midwestern Amish. They actually call the fall and spring the hanging months, because we have seen a seasonal dip in mood, sometimes severe, that goes along with people with depression, and even people who don't have depression could still have a dip in mood. And so the best thing you can do is, if you've identified that you have that pattern, is get as much natural exposure to sunlight as you can, and consider light box therapy. I mean, this is definitely a non-trivial thing for the people who have it. And I can tell you, working on the inpatient unit here, April and November are some of our busiest months.
Wow, that's interesting. This care partner says that my husband has tried different SSRIs. All eventually had symptoms of hallucinations. They went away when he stopped using. Is this a common side effect?
Not at all. Yeah. So usually the SSRIs should not cause or be associated with hallucinations. I will tell you the one place where that might seem like that's happening. So SSRIs and many antidepressants tend to increase our awareness of REM sleep, and REM sleep is when we have dreams. And so, for instance, if these hallucinations are mostly happening at night, it could be that although they're not technically causing more hallucinations, they're associated with vivid dreams that can seem hallucination-like.
Okay. Another sort of side effect question. I was just recently diagnosed with Parkinson's disease. Before this, I was diagnosed with major depressive disorder and was given medication. This increased my movement issues. Could there be a correlation, or should I try again? I still feel depressed on a daily basis.
Yeah, so I'm going to give you an answer that is supported by the evidence. So there is maybe some evidence that in some people, tremor can get a little worse on some of the antidepressants, okay, a little bit. But two things that are really interesting about antidepressants, even before you're diagnosed with Parkinson's, is one, if you're treated with an antidepressant and then later diagnosed with Parkinson's, on average, the people who are on an antidepressant need symptomatic therapy later than people who weren't on the antidepressant. So it seems to push the need for Parkinson's medications down the road a little bit. So clearly it's doing something, and that's controlled for motor severity, meaning that it's not because the antidepressants are having a direct beneficial effect on movement. It's because they're treating the depression, they think. The second is that, and this is something that our studies that we've done at Hopkins show, is that people with Parkinson's who have treated depression versus people who have untreated depression function physically, eating, walking, bathing, hygiene at a higher level than people who are depressed. And so I would say there is a lot of evidence that even if it makes an individual symptom a little worse, being treated for your depression translates into much better overall functioning, both in the short and long term in Parkinson's. And that's been, repeated in many studies.
That's very interesting. The next question is, what are the alternatives to benzodiazepines to treat Parkinson's anxiety? I think we reviewed some of that, but how bad are they? They want to know.
Well, it's funny. I just was out at a conference in Nevada who has one of the top world experts. He's at Harvard right now, and he gave 2 lectures on sleep. And then there was another guy who talked about benzodiazepines. And again, this is their sort of take-home message to us as psychiatrists in general, not specific to Parkinson's, is maybe benzodiazepines aren't as evil as we thought. And I can tell you this, whether they have long or short-term side effects, benzodiazepines will improve most types of anxiety. Benzodiazepines are a medication that works quickly, and benzodiazepines are also wonderful for a lot of the sleep disturbances that happen in Parkinson's, including the REM sleep behavior disorder. And so there's many reasons to consider them. The options are, unfortunately, slower acting medications like the SSRIs that can take 4 to 12 weeks to even start to work. Now, they're probably the better long-term option regardless, and they don't have the downside of the benzodiazepines. But I have to tell you, I use benzodiazepines in people with Parkinson's and people without Parkinson's, always with the idea that we'll decrease and eliminate them if we can once the other medications solve the problem. But I would say this, if you're suffering, don't be too afraid of these medications.
Right. Another question is about, I guess, care partner stress or family stress, because, that happens just with sort of everyday Parkinson's disease. And if you add the mood disorder into it, it can be quite stressful for the care partner. Do you have any words of advice for them in terms of their own mental health?
Well, I have to tell you, the rates of depression in care partners are higher than the general population as well. So the strain of caregiving for someone with Parkinson's is big, and you're not as an effective a care partner when you're depressed. And so I always tell my care partners, and they're usually spouses, but sometimes they're other family members or partners, is if you go down, the wheels fall off the wagon. And so self-care is not selfish is a phrase that you'll hear often. And I have to tell you, I tell the care partner, I'm like, go have book club with your friends, go, have dinner with your friends, take however many hours you need to do whatever it is you enjoy by yourself. Because if you don't keep your batteries charged, nothing, everything you're trying to do is going to be less effective. And so I think that's the main message. And we have caregiver support groups in our communities, our Parkinson's communities. They're an essential part. In fact, most of the time we schedule them at the same time. So the care partner can go to their support group, and the person with Parkinson's can go to theirs. And, you know, I think this is one of the things one of my PhD students is working on right now is how can we better, protect the care partners and utilize them in the care of Parkinson's. And so I definitely think you have to take care of yourself.
That's very important. As we sort of wrap up, I'd like to ask you for some parting advice. So unfortunately, I mentioned before, people still feel there's a lot of stigma associated with Parkinson's disease and also mental health issues in general. So are there any words of advice that you may have that could help individuals sort of overcome that feeling of stigma?
Yeah, no, I think this is one of the things. I think the stigma is on both sides. It's when you enter medicine as a career, I always used to joke with my colleagues as a psychiatrist, I felt like we were the redheaded stepchildren of medicine. You know, we have the same MD degree, but, you know, they say, are you an MD or, you know, you're a psychologist? And nobody would know exactly what you did. But my next thing is the brain an organ? Right? It's a special organ, but it's an organ like any other organ in the body. The heart or the kidney, it's just an organ we know less about.
More complicated, actually.
Absolutely. It's the best organ, in my opinion. And so, you know, I think that's where we have to reframe this whole argument, is that, you know, Parkinson's is a brain disease. Depression is a brain disease. Parkinson's is mediated by loss of brain chemicals. Depression is mediated by loss of similar brain chemicals. And so why we put it, you know, why one is stigmatizing and one less so, I think is, you know, a legacy of, you know, Cartesian dualism, this mind-body dualism. And I think as we evolve as a species, we're going to realize that while the brain is a very special organ, there's no reason to be embarrassed when it, you know, like if you have diabetes, nobody says you're crazy and has all these euphemisms for diabetes, right? I mean, how many pet names do we have for mental illness compared to diabetes or high blood pressure, right?
Very, very wise words. Thank you so much for your insight and expert advice today. It was really greatly appreciated. And thank you everyone for joining us today. I hope you found your time both helpful and educational. And we will send you the link I think Mel mentioned for the recording of this webinar in the next few days so that you can share with others. And always remember, you may not have control over your diagnosis, but how you face the challenges that this disease brings into your life is really yours to determine. So focus on optimizing your quality of life, educate yourself, empower yourself, and celebrate your daily victories. And thank you once again, everyone.